Welcome back everyone to the second part of our little tutorial on arterial blood gas analysis. I'm joined by Graeme again.
It's good to be back.
So I thought, following on from our last discussion, now we're going to sort of touch on how to look at the blood gas and interpret the pH and the acid-base balance. So there's some sort of underlying knowledge which we will try and briefly cover, but if this is a really new topic for you, you probably do well to go away and do a little bit of pre-learning on, or just revision on what is an acid, what's a base, what's pH, what's a buffer. There's lots of different places you can find on the internet, to be honest. I think we talked about some of these last time. The Khan Academy, Anesthesia MCQ, but there's other places as well. So shall we get into it, Graeme? We'll try and briefly...
It's a bit of a daunting topic.
It is. It can be a bit dry. Actually, this is a podcast that I've listened to. These guys are very entertaining. They've got episode 14 is one on Acidbase Physiology, and it's quite good. So if you're into podcasts, that's on iTunes. Just go into iTunes and try and find these guys and have a listen to them.
I think the important thing with acid-base physiology is just to remember the body works best, the human body works best within a narrow band of pH conditions.
That's exactly right. And we're going to really, hopefully, in just like 1 or 2 minutes, summarise that. So, here's the physiology. Don't fall asleep. What movie is this from, Graeme? I just stole this from Google.
I think it's a fish called Wanda.
Yeah.
Am I right?
No, I don't think it is.
You know what it is?
Is it the Anchorman?
Will Ferrell, yes.
Yeah.
I thought it was
anyway,
John
the
Cleese.
physiology. Try and stay awake, Graeme. So, right, the first part, which we're going to have trouble with here. So what is pH and what is hydrogen ion? So I'm going to try and explain it to Graeme, and he's going to roll his eyes if I make a hash of it. So hydrogen ions are actually just protons, aren't they? So they're just a bare proton which is positively charged, and they're quite they can be quite damaging in high concentrations. So they're very what's the word, reactive. So they will bind to and change lots of other molecules very avidly. So that's why if you get too many hydrogen ions and they go running around the body, they can bind to proteins, other important structures, but the main ones being proteins and enzymes and things like that, change their structure. And if you change an enzyme structure, it stops working properly. So basically, in just sort of at high concentrations, or if we don't control the hydrogen ion concentration within a relatively narrow range in the body, all the machinery of the body can start malfunctioning and not working. So that's why the body tries to keep the hydrogen ion concentration in a very narrow range. And so that's the first point. Did I do that okay there, Graeme?
That sounded perfect.
Yep. And the second point is pH. So it's very confusing, isn't it? So the concentration of hydrogen ions is actually incredibly small, and instead of having to write out 0.000000001 millimoles per litre, which is equivalent to a pH of 8 or 7, depends how many zeros I said, I've lost count.
I think the unit was grams per litre.
Oh, grams per litre, yes. But it can be, so basically it's a very small number. It can, I have heard this explained using millimoles per litre as well. So as opposed to the other cations in the body like sodium or potassium, which are 140 millimoles per litre, or 4 millimoles per litre, it's this really tiny number. So that's very confusing. So what they've done is they've done a mathematical what's the word? Transformation, that's the one. Mathematical transformation to make it a more palatable number for us to understand. And it's basically a negative log. And pH stands for, I'm trying to remember, the power of hydrogen ions.
It's negative log,
and it's a negative
base
log.
10
that's
of
right.
the concentration of
so
hydrogen
you don't need to know
ions.
that. All you need to know is that it's a very small number, and that's why they've used pH. But the one thing with pH is that a change of 1, because it's a logarithmic scale, is actually a change of 10. So a pH of 6.5, there are 10 times more hydrogen ions than someone with a pH of 7.5.
Yes.
So it's a small change is a big change. All right.
And I think in medical measurement of pH, there are very few patients who survive conditions where their pH is 6.5.
That's right.
Measured from the blood.
What's the lowest you've seen, Graeme?
I've seen a 6.6 in a man who was stabbed in the chest and exsanguinated.
Did they die?
Not immediately.
Okay, so they did die eventually.
They did die eventually. There
I have
was
seen
one
someone
I read
survive
up.
with a 6.7.
There was one I read from an American magazine, very, very similar situation in the early 1980s, and I think he was the lowest on record, and it might have been below 6.6.
Yep. And this does change a bit with temperature and things too, so hypothermic patients and things like that. But the lowest I've come across was we had a patient who got poisoned by an antiretroviral HOE drug which turned off all her mitochondria, and she had a pH of 6.7 and she survived, luckily. Right.
The other thing to remember is it's the pH in the blood. It's not necessarily the pH in the cells.
That's
and the
right.
pH in the cells are lower.
Yep. Okay, so I think I spent more than 1 minute on that, but hopefully it came across and people can understand it. So the next point that we should make is that humans make a lot of acid. What's the biggest acid that they make, Graeme? Oh, so I've already answered the question.
Carbonic acid.
That's
I
right.
believe.
So carbon dioxide, which is what we produce whenever we make energy in the body, when we're burning our fat and glucose, etc., is actually an acid. And we make huge amounts of it every day. 240 litres, obviously more if you do a lot of exercise. And we get rid of it by breathing, don't we? So that's basically how we get rid of it. So we've already said that we have to keep a tight lid on the pH. So we do keep a tight lid on the carbon dioxide level in our bloodstream, because if we let it get too high and become very acidic, we can cause all sorts of grief with our enzymes and plasma and proteins throughout our body. And likewise, I suppose if it goes too low, that can probably also alter the function because the pH will go too high. So that's basically why we're going to be talking about this in a bit more detail in a few minutes, but that's why we really keep a close lid on the CO2 and why our body has lots of mechanisms to alter our breathing if our pH or our CO2 especially changes. And that's basically, we just change our minute ventilation. So we either increase the size of our breaths, our tidal volume, take bigger breaths, or we increase the rate, so increase our respiratory rate, which I guess the most obvious example is exercise. We're making a lot more CO2, a lot more acid. I've seen it as well in conditions like ketoacidosis. You walk into the emergency department, you see someone sitting down the end of the room who's breathing away. They look like they're puffing so loudly they sound like they've just done a 200-metre race, but they're sitting in the bed, so you wonder why they're doing that.
We see it in pregnancy.
That's
very
right.
often.
I am going to mention that. Good. Very, very preemptive for you, Graeme. And so metabolic acids. So the other acids that we make are metabolic acids. Actually, a huge degree less. The CO2 is by far and away the largest source of acids in our body. But when we metabolize amino acids and various other things, some of them have sulfur and phosphate in them, and that can lead to a small amount of sulfuric and phosphoric acid being made, which is normally excreted by the kidneys.
That's correct.
And we also make ketones and lactic acid. But in normal individuals who aren't unwell, those ketones and lactic acid, which are acidic, are then metabolized usually by muscles or the liver, which then make basically metabolize the acid. So it's sort of like the net production of acid is actually zero.
Yes.
Unless something bad's happened.
Exactly. Ketones and lactic acid can be normal fuel.
Yep,
for
that's
many
right.
cells.
But I mention them because obviously when you have some pathological states, which we might hopefully discuss later on, they're a really important cause of serious acidosis in people with certain conditions. Okay, I thought this is a picture of you 5 years ago during your running days.
Yes.
When you had a bit of hair and
bit of muscle mass, I think.
Gym more often. So I'm trying to remember. I actually forgotten what this was trying to segue into, but I'm pretty sure I'm trying to talk about how we. That's right. So when we sprint 400 metres, like Graeme here is doing in this picture, we're going to make a huge amount of acid. How are we going to stop ourselves from becoming very acidemic and all of the cells and mitochondria in our body stay rupturing and splintering and not working properly?
So
we're going to buffer it, aren't we?
Exactly.
So this is a really important concept as well that we have to understand is that the body has very huge capacity to soak up acid, or soak up any acid that's produced, and prevent it from actually making the pH change much. So a buffer is a bit like it's how would you phrase it? It's like a
sump.
Yeah, it's like a sump or a sponge or something like that. It can just soak up. So it can soak up the hydrogen ions that are produced, and then it can also release hydrogen ions when the pH gets too high or too alkalotic. And so this basically, even though there's going to be a huge change, you can make not much acid when you're sitting around doing nothing, and then when you're exercising vigorously, or if you're febrile, having a septic event, you can make a huge amount of acid, and this allows the body to keep the pH still within that range that is safe for the human body to function.
Yeah, and just to remind people listening, it takes ideal pH conditions for things like the heart to pump, for the blood to clot.
Yep, that's
as
right.
examples.
So all of those important functions of the body don't work properly when the pH gets too deranged. So the most important buffers in the body are actually hemoglobin, because that's very good at binding excess carbon dioxide, which is, as we already mentioned, the most common acid, and the bicarbonate system as well. So what happens is, and we'll talk about this I think on the next slide, that the interaction between carbon dioxide and bicarbonate. There's some other molecules in the body which also apparently are important buffers, like albumin, and in chronic acidemic states, things like bone and the phosphate in your bone and things like that are also important. But, right, this is tricky. This is a pretty important equation though, isn't it?
It is.
So if you want to understand a blood gas, a natural blood gas analysis, you really have to know this equation. So not the one at the bottom, you don't need to know that one, but you do need to know this chemical equation at the top here, which is the fact that carbon dioxide on one side and bicarbonate and hydrogen ion on the other side. So how are we going to explain this? So when you make lots of carbon dioxide, it combines with water, and you can see it moves across to the right and produces, because it's carbonic acid, can produce hydrogen ions and bicarbonate.
Yep.
And if you put hydrogen ions, or if you make lots of acid, you can then use this system to buffer. So there's a lot of bicarbonate in our body, and whenever extra acid is produced, that bicarbonate can soak up the hydrogen, and it just creates, it increases the amount of carbon dioxide that's produced, and of course we can easily breathe that out. So that is the most important buffering mechanism in our body. Do you think I explained that all right?
Yep, not too bad.
Good. Yep. So that is the main problem, and it can move back the other direction as well. So sometimes if we have problems with our breathing, the bicarbonate can help as well. So that is the main buffer. All right. So I just want to briefly mention. So when we talk about acid-base disturbances in the body, there's only really 4 things that we're talking about, because there's only really respiratory acids and metabolic acids, and they can either be too high or too low. So we're talking about an acidosis or an alkalosis.
An acidosis if the hydrogen ion concentration is too high, and an alkalosis if the hydrogen ion concentration, if the bicarbonate concentration is too high.
Yeah, that's right. So we're going to move back. So it's really important to understand, and we might just get this by repetition as we move on. But bicarbonate is often what you look at when you're trying to assess metabolic acidosis, even though the bicarbonate is actually the base. I think hopefully we haven't confused anyone.
Yeah,
there.
It's a bit tricky. I think.
So that's why you do need to understand that equation, don't you?
You do, and also you need to look at the pH.
Yep.
To see whether there is an acidosis. Yes. Or an alkalosis.
That's right. So so now I think we're getting up to the point of the talk where we're going to talk about how to actually systematically look at the blood gas. But the first thing, let's just go back. So these are the 4 primary disorders. So you can have a primary problem. Something goes wrong in your body. If something interferes with your breathing, you get pneumonia, or someone gives you some oxycodone and you stop breathing as much as you should, so you get more CO2 in your body and you become acidotic from the carbon dioxide. It's a respiratory acidosis. Likewise, you can blow off too much CO2, you might be breathing too fast, or you can get a metabolic acidosis where some non-volatile acid, so basically things like ketones or lactate or salicylate build up and you become acidotic, or you can have not enough acid and you become alkalotic. So we've already covered that, I think. But then
how would you lose metabolic acid and become alkalotic?
Yeah, so vomiting stomach acid. So prolonged vomiting is the commonest one that's talked about. But there are other things as well, like diuretics. We can talk about that later, maybe. But the important concept is that usually when one of these things goes wrong, the body tries to compensate. So usually you have some compensation. So if you get a the classic one is if you get a metabolic acidosis, you usually try to again bring the pH back to normal by breathing more and getting lowering your CO2. So it can be a bit confusing on a blood gas because often there's two things have changed, and one of them is the primary disorder, which is the disease state causing the problem, and then the other is the respiratory or the metabolic sort of compensation, which is usually in the opposite direction, trying to bring your pH back to normal and keep everything okay.
So the diabetic acidotic is unable to use sugar, generates large amounts of ketones, for example.
Yep.
And that leads to more hydrogen ion production, which drives CO2 production.
Yep.
Causes increased respiratory effort.
Yep, that's right.
The metabolic problem is primary. The respiratory changes are compensatory.
That's right. So when you're looking at a gas, though, so you have to have a systematic approach to looking at your blood gas to try and figure out which is the primary one and which is the one that is just trying to compensate. And we'll go through that. It gets easier when you do more and more, and there's some common conditions. Usually, it's only the obscure conditions that trick people. All right. So when you're looking at a blood gas, you've got to have in your head what is the normal values. So these are the ones that everyone teaches. pH is 7.4. Now, I have heard this. Some people talk about ranges, but actually, when you're looking at a blood gas, you can't do the maths that you need to do if you've got a range. So you're better off to just remember these, if that makes sense.
Yep.
Better off to remember the value, the single unitary values. So the pH of 7.4, a PCO2 of 40, a bicarbonate of 24, and a PO2 of 100. Now, you're not going to really be looking at the O2 when you're doing the acid-based stuff, but I just chuck that in there anyway.
Yeah, and just to remember that the venous blood gas will be lower than an arterial blood gas with a PaO2 of 100.
That's right.
Yeah.
And there will be very slight changes in the pH and PCO2, but not enough to be worth remembering, to be honest.
Exactly.
But what about when you're pregnant? Well, actually, so there's two things. You can either try and remember these ones and have a set of normal values for being pregnant, or, this is what I do, just remember these normal values for a normal non-pregnant person, and then when you look at the blood gas of the pregnant person, just remember it's normal for them to have a compensated respiratory alkalosis.
That is
which
correct.
is what they have there. So basically, when you're pregnant, you do it's thought the progesterone is the main driver. You do breathe at a higher rate, and you have a chronically lower PCO2 and a slightly higher pH. Now, what's the reason for that, Graeme?
The reason for that is, it's the effect of the progesterone.
Yep.
Leading to increased
Why is
respiratory
that advantageous
drive.
for the pregnant woman?
It assists in excretion of metabolites from the fetus.
Yep.
In order to enhance the movement of carbon dioxide and other waste products down a concentration gradient from the fetus.
That's right.
To the mother.
That's my understanding. So it's really these changes have come about through evolution, presumably, because it helps the fetus.
Mm.
Yeah. If it increases gradient and helps gas exchange across the placenta.
Yeah.
Right.
It also makes the woman potentially a little more vulnerable to things like metabolic acidosis, because there's a lower bicarb than found in other people.
It's true. So they have less buffering capacity, and they're already their ability to increase their CO2 excretion or breathe harder has already been taken away from them. Okay, so this is the 5 steps of an ABG analysis which I use. Now there's lots of different ways on the you can look up on the internet. We're just going to, for this talk anyway, we're going to go through it. This is the way of analysing the ABG to assess acid-base status. What is the pH? So if it's less than 7.4, you're acidemic. If it's more than 7.4, you're alkalemic.
It's interesting, they're different words: acidemia, acidosis, alkalemia, alkalosis.
Yep, and to be honest, in practical everyday terms, I don't know whether it's worth us getting into that debate here, but I would use the word emia when you're looking at the pH, because that's the overall status. Sometimes you can have a couple of 2 or 3 different disorders all occurring at once, and what you want to know is what's it all added up to. So here we go. What's this one, Graeme? So we're going to analyse this blood gas through these 5 steps.
Yep.
So is this an alkalosis or acidemia or an alkalemia?
Well, going on that normal range, you could say it's normal, but it is actually
7.4.
It's actually an acidemia.
Yeah, that's right. We're going to use so that's why that's a good point. But some of the teaching I've heard, and this is what I do. Just ignore the ranges and stick with those numbers. So if it's less than 7.4, it's an acidemia.
Yep. Good.
Right, the next thing I look at is what's the CO2? Is it high or low? What's the normal number of CO2?
40.
That's right.
Yep.
So I haven't told if this is pregnant or not, but we'll just assume it's a non-pregnant person. Let's have a look. What's this person's CO2?
So this patient has a low CO2?
So do they have a respiratory acidosis or alkalosis?
It's likely to be a...
we can get onto that later.
Yeah, exactly.
All we need to take note of at this stage,
It's low.
it's low. All right, what's the bicarbonate? So a low bicarbonate is indicative of a metabolic acidosis. If you can remember that equation we had with carbon dioxide and water and bicarbon hydronides, or if it's high, it's an alkalosis. So let's have a look at our gas again.
So the bicarb is low, so it's likely to be a metabolic acidosis.
That's right. So the pH is low. They have an acidemia, and the bicarb is low, so they have a metabolic acidosis. So now we're going to try and match this up and figure out what is the primary condition and what's the compensatory condition. So I've already said that the overall status of the patient is acidemia, and we have a metabolic acidosis. So it's probably a metabolic acidosis because the bicarb is low, the CO2 is low, and that's actually a respiratory alkalosis.
It is, yeah.
So what have we decided?
So I think it's a primary metabolic acidosis with respiratory compensation.
Exactly. Yep.
And I think that's
correct.
why I hesitated with that second question.
Yes, that's right. Now we're not going to get into this, but base excess, which is on most blood gas machines now, will tell you whether there's a metabolic acidosis. So I was talking about the base excess. So this is referring to metabolic acids in the body. If it's a negative number, that means obviously there's a negative amount of base, so there's more acid in the body. So it's outside the normal range. It's greater than 3, so it's also telling you there's a metabolic acidosis present.
Yeah, or less than -3.
That's right.
Yeah.
Less than -3.
Yeah.
A bit confusing.
It is.
Because bases are the opposite of acids, and so you have to look at the negative number. So is there compensation? Yes, we've already ascertained that, haven't we? We've skipped ahead. So we said that there's an acidemia, and it's a metabolic acidosis, and that's the primary condition. And we've seen that the CO2 has gone down, so there is a compensatory respiratory alkalosis. So the patient has, for some reason, something bad has happened to them. They've got a metabolic acidosis, and they're trying to compensate by breathing harder. Is that right?
Yep.
Summary?
Yep.
Okay, we're going to stop here, but before we move on, I am just going to say that there is more to it than that, unfortunately, because sometimes, the more, the further analysis you've got to do when you're looking at these patients is you've got to move on from this, you've got to try and decide, is there compensation, and if so, is it appropriate? And then it gets tricky when patients have more than one condition. So sometimes they just have a simple condition, and then they have a simple compensatory response to it. But sometimes they have 2 or 3 things wrong. You can get patients who are shocked and have a metabolic acidosis from lactic acidosis because they're not perfusing their body properly. But because they're shocked, they're also semi-conscious and they're not breathing. So they have a respiratory acidosis as well, and they have two things wrong with them. And then maybe they've been vomiting for 3 days and they have a metabolic alkalosis from all the hydrochloric acid they've vomited up. And then that's just way too confusing. So we will try and talk about that, but we're not going to do that now. We're going to stop because I'm getting a sore throat, and I think our listeners are starting to turn off. Any final comments?
No, I agree.
So what do you think of the take-home points, Graeme?
To be systematic in the approach to looking at a blood gas.
Yep.
What's the pH? What's the PCO2? What's the bicarb? Is there a compensation?
That's right. So I think, and the key to that is maybe just practicing. So just practice those first 5 steps on some simple, straightforward blood gases. Have a look. You can find them on the internet. There's plenty of examples. Or if you're working in a critical care area, just practice going through straightforward ones and practice those rules. And then once you get that down pat, you can move on to looking at some more complicated sick patients who have some complicated work, and perhaps look at some the compensation and mixed acid-base disorders. Okay, thanks, Graeme. That was really good.
Thanks, Roger.